Imagine you're performing a flawless midline laparotomy. You run your closure perfectly,
Okay.
and you step back knowing there's still like a flip of a coin chance, up to 53%,
Yeah.
that your patient is going to develop a hernia.
Yeah, it's honestly a sobering statistic. And, you sent over this incredible stack of notes for our deep dive today, focusing on abdominal wall reconstruction.
Right, AWR.
Exactly. Because, the obesity epidemic plus the rise of minimally invasive techniques, it just means fewer general surgeons are comfortable managing these massive open abdomens.
So the difficult cases inevitably roll downhill to us.
Oh, 100%. And the clinical reality is you just can't fake your way through an abdominal wall reconstruction. You are dealing with dynamic loads, fluctuating pressures, failing materials. It's the ultimate proving ground for our specialty.
Which is exactly our mission today. We are breaking down the exact physics, the surgical techniques, and the decision-making algorithms you need for complex AWR, from eviscerated abdomens in the ICU all the way to massive loss of domain hernias.
Yeah, and before you even think about picking up a scalpel or, deciding what mesh to pull off the shelf, you really have to understand the mechanics of the abdomen under pressure.
Right. I always try to conceptualize the abdomen as a pressurized cylinder. Like, the posterior third is essentially rigid, right? The spine and the retroperitoneum kind of handle themselves.
Legs fixed.
But the anterior and lateral portions of that cylinder are entirely dynamic. So what happens mechanically when that system is challenged?
Well, think about a normal Valsalva maneuver. When a healthy patient inspires or braces to lift something heavy, the diaphragm descends. Intra-abdominal pressure spikes immediately.
Right.
But in a healthy system, that internal pressure is matched instantly by an increase in the tone of the abdominal wall muscles. You get this uniform counterpressure across the entire cylinder.
But that physics only helps if you have an intact system. What happens when that uniform counterpressure actually fails?
That is the exact moment deformation begins. Episodic high pressure from chronic coughing or just getting out of bed. It starts to push mobile viscera against the fascial weak point.
And this is where we have to clinically distinguish between a bulge and a true hernia.
Exactly.
Practically speaking, though, when I'm examining a patient in the clinic, a bulge and a hernia can look totally identical. Is the distinction just semantics? Or does it actually change the physics of what we're dealing with?
Oh, it changes the physics completely. So a bulge consists of an intact abdominal wall. It might be stretched or denervated or, thinned out from a previous resection, but the fascial layers are contiguous.
Right, they're still connected.
Yeah. If you look at it in cross-section on a CT scan, a bulge forms the smooth, broad curve. A true hernia, on the other hand, is contained only by a fragile sac of scar tissue. It forms a distinct, narrow-necked omega shape.
And that omega shape is the mechanical trap. Because of that tight fascial neck acting as a fulcrum, true hernias carry a massive risk of bowel incarceration. The bowel slips in, driven by pressure, and the mesentery just gets caught on the rigid lip of the fascia.
Yeah, venous outflow gets compromised, and it strangulates. But bulges carry zero risk of incarceration because there is no rigid neck.
Which completely dictates your surgical indications. We operate on true hernias to prevent ischemic bowel obstruction.
Right.
We operate on bulges only if the mechanical stretching of that tissue is causing the patient severe, debilitating pain. Otherwise, you just leave a bulge alone.
Here's the key point on how those two entities progress, though. Hernias will expand relentlessly over time. Scar tissue inevitably yields to continuous pressure, so they rarely ever reach a steady state.
The bulges stabilize.
Yes, they start growing once the inelasticity of the stretched fascia matches the pressure drop that naturally comes from having a larger intra-abdominal volume.
That makes sense. We also need to talk about the muscle physiology here. In these massive hernias, the actual function of the rectus and oblique muscles fundamentally changes.
Oh, totally. Consider the normal mechanics. When you Valsalva, your muscles lock down. They undergo isometric contraction. They build tension, but the sarcomeres aren't actually shortening.
Right, creating a rigid torso to transfer force.
Exactly. But look at a patient with a massive ventral hernia. The viscera just escape out the front defect. The muscles attempt to contract, but they can't build pressure against a void. So the muscles actually shorten. They undergo isotonic contraction.
Wow, so it becomes a huge energy expenditure issue. Because isotonic contraction burns significantly more metabolic energy than isometric. You're basically wasting effort just trying to stabilize your core.
Yeah, and it destroys the diaphragm's ability to push off against a pressurized core for basic respiratory function. You were looking at total biomechanical dysfunction between the chest and abdominal compartments?
And the larger the defect, the worse the respiratory derangement. Plus, you add obesity into the mix. Obesity acts as a mechanical double hit.
It really does. First, you have an increased volume of intra-abdominal visceral fat, which chronically raises the baseline internal pressure pushing outward.
Right.
Second, the abdominal wall has to physically support a massive amount of external adipose weight hanging anterior to the center of gravity. Every single cough, every transition from sitting to standing, it multiplies the shear stress directly at your suture tissue interface.
Which brings us directly to the engineering of the repair. Since a hernia is a failure to contain pressure, how do our surgical techniques actually alter those forces?
Well, let's talk about bridged repairs.
Yeah, I see attendings doing bridge repairs all the time, just sewing a piece of mesh across the open gap, like a rigid lid. I mean, it's faster, it keeps you out of the lateral retrorectus space, you get out of the OR sooner, but you argue against it strongly. Why?
Think about the force distribution. In a bridged repair, that piece of mesh has to bear 100% of the intra-abdominal pressure. The entire strength of your repair depends solely on the circumferential sutures attaching the mesh to the innervated muscle.
And the larger the hernia, the further the center of that mesh is from solid vascularized tissue.
Exactly. It acts like a trampoline. Over time, it is basically guaranteed to bulge outward.
Yeah, and in real life, the failure mode here is rarely the mesh tearing. It's almost always the sutures pulling through the native tissue over time. I describe it to my residents as a wire cutting through a block of ice. Constant dynamic tension eventually wins.
That's a great analogy. To stop that wire through ice effect, you have to completely alter the force distribution. That is why direct supported repairs are non-negotiable for large defects.
So you approximate the native fascia to reestablish the midline, and then you augment that closure with mesh.
Right. You shift the mesh from being a load-bearing lid to a load-sharing reinforcement.
And load sharing drops your long-term failure rates. But where you place the mesh matters just as much as whether you use it.
Oh, absolutely. Intra-abdominal underlay placement is the most biomechanically sound approach. You are leveraging Pascal's principle. You use the patient's own visceral pressure to push the mesh flat against the posterior aspect of the abdominal wall.
But you need a wide zone of contact, right?
Yeah.
At least a 3-centimeter overlap extending past the fascial edges all the way around.
Minimum 3 centimeters, yeah. That wide surface area smooths out the compliance mismatches between the stiff synthetic mesh and the dynamic, yielding lateral wall.
And when you're securing that mesh, suture spacing is everything. Instead of thinking about it as just putting in enough stitches to hold it, I tell my residents to think about it like placing rivets on an airplane fuselage.
That is the perfect mechanical visual.
Right. Because if you place too few rivets, the gaps are too wide, the cabin depressurizes, and in our case, a rogue loop of bowel slips between the stitches and herniates. But if you throw in too many rivets, too close together, you compromise the structural integrity of the metal itself. In the abdomen, placing sutures every millimeter strangulates the blood supply. You cause ischemic necrosis of the fascial edge, the tissue dies, the mesh detaches, and your repair fails catastrophically.
Yeah, and, physics and engineering are great when you have relatively intact tissue in an elective setting, but what happens when the biological structural integrity is completely gone?
Oh, we have all been there. It's 2 a.m., you get a consult for an ICU patient who is packed open, septic, and sporting massively edematous bowel. The fascia is retracted and simply will not close. What is the immediate survival strategy?
First step is evaluating the timeline. Timing dictates your entire approach. If you have a fascial dehiscence less than 1 week post-op, that patient carries a high risk of evisceration. The bowel loops haven't fused yet.
So you usually need to take them back to the OR for exploration.
Exactly. But if they're over 2 weeks out, there are usually enough dense adhesions holding the bowel matted together that you can treat the abdomen as a standard, albeit massive open wound.
Common pitfall here, though, forgetting to check the patient's medication list for steroids.
Oh, great point.
If they're on chronic high-dose steroids, the inflammatory phase of wound healing is blunted. It can take up to 3 weeks for those bowel adhesions to get strong enough to prevent a spontaneous evisceration.
Very true. So you're scrubbing in, the bowel is swollen beyond belief, the field is grossly contaminated, and primary closure is a physical impossibility. Your goal is strictly damage control and temporizing closure.
Right. Keep the viscera contained, let the third spaced fluid egress, and prevent abdominal compartment syndrome.
Yeah. I reach for an absorbable polyglycolic acid mesh, like polygalactin. Run it to the lateral fascial edges. Bridging the defect with this instantly increases the intra-abdominal volume, relieving the compartment pressure.
And more importantly, it's highly porous. So all that toxic cytokine-rich fluid drains directly through the mesh into a subatmospheric dressing on top.
Here's an absolute non-negotiable rule in this setting, though. Never use permanent heavyweight polypropylene mesh over exposed bowel.
Never.
It seems tempting because of its tensile strength, but do not do it. Heavyweight polypropylene causes fierce, dense adhesions directly to the serosa. The rigid structure of the plastic erodes right into the distended bowel wall,
Causing massive extrusions and multiple intracutaneous fistulae. They tried it decades ago and completely abandoned it because the complication rate was lethal.
Right. So stick to the absorbable polygalactin. And the biological visual cue you're waiting for happens a week or two later. Once the patient stabilizes and the bowel edema recedes, you will actually see the absorbable mesh start to wrinkle and sag.
Which tells you the intra-abdominal volume has normalized and it's time for early soft tissue coverage.
Exactly. Skin grafting is your workhorse for this stage. You remove whatever is left of the absorbable mesh, and you're staring at a thick, beefy red sea of granulation tissue covering the matted bowel.
The operative technique here requires incredible finesse, though. You use a large periosteel elevator or the back of a scalpel handle and bluntly scrape only the superficial layer of the granulation tissue.
Yeah, you just want to remove the fibrinous exudate. You absolutely do not want to separate individual bowel loops. Keep them safely glued together.
And skin grafts survive here because they rely entirely on the rich capillary network of that granulation tissue. They heal in 2 dimensions, requiring relatively little metabolic overhead.
Which is key because it completely ignores the patient's terrible systemic nutritional status. This is the exact opposite of mobilizing massive 3-dimensional sutured skin flaps, which will just undergo tip necrosis if the patient's albumin levels are sitting in the basement.
Okay, let me throw you the nightmare scenario.
Bring it on.
What if you have an active fistula right in the middle of that open granulation bed? You have no overlying soft tissue to help it seal, and liquid stool is actively pouring into your wound.
Ugh, that is one of the hardest consults in our specialty, because you cannot graft over a high-output fistula. The trick is converting that chaotic mid-wound fistula into a functionally managed stoma. You plan to skin graft all the healthy granulation tissue surrounding the mucosal hole.
But succus entericus is packed with proteolytic enzymes. If that fluid touches your newly placed split-thickness skin graft, it digests the delicate fibrin bonds holding the graft to the bed within hours. You will literally watch your graft wash away.
Yeah, it's brutal. So to prevent that enzymatic digestion, you have to isolate the output. You place a soft rubber Malcot or Foley catheter directly into the fistula tract, and you hook it up to continuous low-wall suction.
Creating a localized vacuum.
Exactly. It actively pulls the succus entericus away from the wound bed before it can spill over. You maintain that continuous suction for at least 48 hours to keep the field totally dry while the graft adheres and vascularizes.
And once the graft truly takes, you remove the catheter, place a standard ostomy appliance directly onto the new skin graft, and you just bought yourself the 3 to 6 months you need for the entire abdomen to soften before attempting definitive reconstruction.
Beautifully said. So fast forward 6 months, the patient is nutritionally optimized, the skin graft over the bowel is pliable, and it is time for the definitive reconstruction of a massive midline defect. We need to mobilize native tissue to achieve a supported fascial closure.
This is where the component separation technique becomes the gold standard. You radically excise all the scarred, thin central tissue, carefully dissect the skin graft off the underlying bowel, and advance healthy, innervated rectus muscle back to the anatomical midline.
Right.
But, I hear a lot of skepticism from junior attendings about the mechanics of this. If we incise and release the external oblique aponeurosis to get that massive medial advancement of the rectus, aren't we just trading a central midline defect for bilateral lateral weakness?
Yeah, I hear that too. It seems counterintuitive when you look at it on a whiteboard. But mechanically, the opposite happens. The lateral abdominal wall is composed of 3 muscle layers.
Right.
Releasing just the outermost layer, the external oblique, allows the rectus muscle to slide 8 to 10 centimeters medially per side. Because you still have the internal oblique and transversus abdominis intact, that massive lateral release actually improves the compliance of the lateral abdominal wall.
And by improving that compliance, you significantly increase the total intra-abdominal volume. That is what prevents abdominal compartment syndrome when you shove all that loss of domain bowel back inside the cavity and close the midline.
Exactly. The surgical approach to reaching that external oblique is critical, though. A major error is performing wide, sweeping midline undermining of the skin and subcutaneous tissue all the way lateral to the linea semilunaris.
Oh, yeah. If you do that, you will systematically sever all the periumbilical rectus perforators and completely devascularize your anterior skin flap.
Right. Instead, use a perforator-sparing approach. Make small, 6-centimeter transverse incisions laterally at the inferior border of the rib cage. Tunnel down bluntly, identify the external oblique, and release it under direct vision.
You save the blood supply to the skin. And here's another absolute pitfall to avoid. Under no circumstances should you release the internal oblique or the transversalis fascia during this dissection.
Never. If you mistakenly cut through those deep layers, you destroy the remaining structural integrity of the lateral wall and create a true iatrogenic semilunar hernia that is incredibly difficult to fix. You only release the external oblique.
Let's look at the recurrence rates, because the data really dictates our next move here. If you perform an unsupported component separation, just pulling the muscles together and sewing fascia to fascia, you still face a 24% long-term failure rate.
The dynamic tension is just too high.
Exactly. But if you add a soft polypropylene mesh as an intra-abdominal underlay to load share that tension, the recurrence rate plummets to near 0%.
Which forces us into the complex algorithms of mesh selection. Because the material properties of the mesh dictate your specific complication profile. Let's look at permanent synthetic mesh, like PTFE.
PTFE is highly engineered. It encapsulates tightly, it shrinks predictably, and because it has a microporous, smooth, visceral surface, it forms very few dense bowel adhesions. Fantastic for perfectly clean surgical fields.
But the mechanical trade-off is its stiffness. You have to lay it perfectly flat against the abdominal wall.
Right? Any wrinkles or folds in that stiff material create localized point pressure. Over time, that point pressure will cause the mesh to erode and extrude right through the overlying skin, or worse, fistulize into the underlying bowel.
On the other side of the spectrum, you have bioprosthetics, acellular human, or porcine dermal matrices. These are your absolute go-to for contaminated fields, or in cases where you are doing a concurrent bowel anastomosis.
Because they integrate.
Right, they actually vascularize and integrate into the native tissue rather than just being encapsulated by scar.
But there's a massive biological trade-off with bioprosthetics. You are racing against degradation.
Exactly the issue. The faster a bioprosthetic integrates and vascularizes, the faster host collagenases break it down, causing it to lose its structural integrity. Human dermis, for example, integrates beautifully and very quickly.
But because of that rapid turnover, it stretches out and fails mechanically much sooner. Cross-linked porcine dermis takes significantly longer to integrate, meaning it acts more like a synthetic for the first few months. It might encapsulate a bit more, but it maintains its tensile strength far longer.
Yeah, you have to constantly balance infection resistance against long-term mechanical durability based on the specific contamination level of the patient in front of you.
But even if you execute a flawless, tension-free fascial repair with the perfect mesh, if your overlying soft tissue envelope is compromised, your entire reconstruction is doomed. We focus so heavily on the structural muscle layer, but securing coverage for massive circular defects over irradiated tissue or hostile fibrotic wound beds. That's where the reconstructive puzzle gets incredibly complex.
It really does. The fascia requires a healthy, well-vascularized, pliable skin envelope to survive. The blood supply from the skin flap actually feeds the anterior fascia. So if you have a massive circular defect, maybe from radical debridement of a necrotizing soft tissue infection or a massive full-thickness tumor resection, you can't simply pull the skin together.
Right. For narrow transverse defects, you can often do a pinch test, flex the patient's bed into a beach chair position, and close it primarily like a standard abdominoplasty.
Yeah.
But for large circular defects where the geometry works against you, propeller flaps are an incredible tool. You identify a dominant periumbilical perforator on a pre-op CT angiogram, confirm it in the OR with a handheld Doppler, design an elliptical island of skin around it, dissect the perforator down to the fascia, and literally rotate that island of tissue 180 degrees on its vascular axis right into the defect.
And the bottleneck isn't usually arterial inflow, it's venous congestion from twisting the pedicle. Now, if the defect is situated in the lower abdomen or groin, pedicled thigh flaps like the vastus lateralis or the anterolateral thigh flap, the ALT, are incredibly robust and reliable.
And here's a mechanical pro tip for those thigh flaps. If you're trying to reach the mid or upper abdomen with an ALT and you're coming up short on length, do not just pull harder on the pedicle.
You don't.
Divide the rectus femoris muscle pedicle and pass your ALT flap deep to the rectus femoris rather than over it. Passing it deep shifts the pivot point proximally, and you will gain several crucial centimeters of reach, significantly reducing the tension on the anastomosis.
Such a great tip. And for massive upper abdominal defects where thigh flaps cannot reach, tissue expanders placed subcutaneously over the rigid rib cage work beautifully.
Because the ribs don't yield.
Right. All the expansive force is directed outward, rapidly generating new vascularized skin that you can advance inferiorly over the upper abdominal defect. The overriding principle here is that your soft tissue strategy dictates your fascial strategy. If you cannot absolutely guarantee healthy, reliable skin coverage, you should lean heavily toward using a bioprosthetic mesh, so your deeper fascial repair has a chance of surviving the inevitable superficial wound breakdown.
So this has been an incredibly high-yield breakdown of the mechanics. Let's pull the key practical points together. You must respect the physics of the pressurized abdominal cylinder. Utilize load-sharing, supported mesh repairs to prevent that wire-through-ice suture pull-through effect.
Absolutely. And for your damage control open abdomens, avoid permanent heavyweight mesh entirely. Rely on temporizing porous absorbable mesh. Manage the fluid shifts and get skin grafts onto that granulation tissue early.
And when you're performing definitive component separation, preserve your perforators by avoiding midline undermining. Rely strictly on external oblique releases to gain your lateral compliance without destroying the deep fascial integrity.
Just keep the structural engineering principles at the forefront of every decision.
So true. Before we wrap, I want you to think about where this entire field is heading. We spend massive amounts of time debating permanent versus bioprosthetic materials, constantly balancing long-term tensile strength against acute infection resistance.
Yeah.
But as tissue engineering rapidly advances, imagine a near future where we don't have to make that compromise. What if we could deploy a completely synthetic matrix that perfectly induces native fascial regeneration without any chronic encapsulation?
Oh, that would change everything.
You place the scaffold, the body actively rebuilds its own unyielding pressurized collagen cylinder along the lines of force, and then the synthetic matrix simply vanishes, leaving behind nothing but native anatomy. Something to think about before your next complex laparotomy closure. Because at the end of the day, when you are staring down into an open abdomen, you are not just a surgeon moving soft tissue, you are an engineer, actively rebuilding the core of human biomechanics.